I think just call our people. They can come and sit.
Hello, Nirav, the other link is open, right?
Nirav, yeah.
Madhura, you can check that.
Usually there will be a lag between this and that.
Yes, it's like I could join.
Dr. Akash, we can start in another minute and we'll be live with.
Okay, we'll start.
Yes, sir, please go ahead.
Yes, sir.
Yeah. So, good evening, all dear friends. So, welcome this unique initiative that is called GLAD. So, GLAD is Gastro Liver Academic Discussion Forum. So, this is our motto is to empower the nation with primary gastro and liver care. So, this is a unique effort under the mentorship of Professor Subrata Acharya, who has given the insight that the things should go far from the top end specialists because India lacks the so skilled doctors at each level. And this is further assured by Professor Akash Shukla from KEM and also Dr. Bedi Goswami from Guwahati. And then me, myself as Dr. Ashok Chaudhary. So we all three thought of making a course module. And with that, we have 12 people as a editorial board who are across the globe. So what is our planning is that we'll go for important clinical issues every monthly. So we fix is the fourth Friday in a virtual mode for the presentations. And here you will bring interesting cases. We'll do case-based discussion for the challenges we are facing as a primary care physician, as a gastro liver consultant, what he can guide and mentor you. Then we go to important clinical issues or clinical topics like today we are covering the jaundice. Then we'll cover ascites and some important topics every monthly. And to make it more fruitful, so we'll go with a very interesting newsletter. The newsletter will be a recollection of what we discussed, the case with what are the snippets or the learning points, and then with what is new, and that is the primary. So that is from the academic part. And for that, what we are planning is that all our gastroenterologists who are a part of this GLAD, they will do a physical meet at the local level where he can do all the interested people. So we need just any doctor. He may be MBBS, he may be MD, who may not be having any other curriculum also, but he has interest for the gastroenterology and hepatology practice. So what we want to know that you should know the liver disease, the gastrointestinal symptoms, early warning signals, primary basic care management, and the referral, so that we should not delay. So that is the whole motto of the concept. And in this part, so you will be have a physical meet, and after the meeting is over, you can put the questions. And for that, we request that you have to give a registration. I think most of the people today has been registered, and we will be frequently contacting over this mail. And also we request in the every month first week, you suggest your topics, you send your case scenario in the mail, so that we'll make the preparations for that. In second week, we'll prepare about the making the case outline and the structure with the faculty and the guest speakers and the panelists to be there. And in third week, we go with the detailed program. And on the fourth week, that is today, the glad day, we go for the conference. So we request everyone's participation for this topic, for these areas. And here we can see much more. So we are now thinking that you should know about the basic skills, how to empower the things. And subsequently, we will also make it for if you're really interested for the collaborative works as per the medical is concerned. So this is from my side. So I request Professor B.D. Goswami just to say a few words. Sir, I'll request Professor Goswami for the 2 minutes, how you think that this GLAD is going to be help you. And then we'll transfer this session to today's speaker and chairperson, Dr. Akash Shukla. Thank you.
Dr. Goswami, you are on mute.
Thank you, Dr. Chaudhary. Last month, we discussed first in Guwahati regarding this whole project to ensure the physicians or any MBBS doctors in the country so that they can practice and they can help the patients in the field of gastroenterology as well as in hepatology. We have got so many meetings for the gastroenterologists in national level or regional level for the academic activities, but for the practicing gastroenterologists or the physicians, we should do something more, and that's why we should go and outreach them. That is the motto. Already you have outlined the whole thing, and in future definitely in contact with Dr. Akash Shukla, Asarji sir, and also the other connected people will try to make it possible and we'll do our best. Thank you.
Thank you, Dr. Goswami. So I welcome all of you. And on behalf of GLAD, on behalf of Dr. Acharya, Dr. Chaudhary, and Dr. Goswami, welcome to this first GLAD day. And this is something which we envisaged very recently. We realized that 95% of the population is not treated by gastroenterologists when they have a GI or liver problem. And therefore, it is important that these people get empowered who are treating 95% of the population. And that is the whole idea behind this GLAD day. Without much ado, I will start with the first discussion. And I would like to really thank Ashok to allowing me to be the first speaker on the GLAD day.
Yes, sir. Please.
So I'm Dr. Akash Shukla. I'm the professor and head of Department of Gastroenterology at Seth GS Medical College and KEM Hospital. And I'm also the director of hepatology at Sir H.N. Reliance Foundation Hospital, Girgaon, Mumbai. So I will be talking about in the next 20 minutes on approach to a patient with jaundice. Now, this is something which we have learned right from our first year levels, first year MBBS, that the bilirubin metabolism happens in the body. The hemoglobin breaks down to bilirubin, and there the bilirubin will then go to the liver where it gets conjugated, and then it gets excreted in the canaliculus and finally comes out through the bile duct into the intestines. Now, if you have a problem before the bilirubin reaches the liver, for example, excessive breakdown of hemoglobin or impaired uptake of bilirubin, then this is called as pre-hepatic cause of jaundice. If there is a problem in the liver, then you call it hepatic cause of jaundice. And then you have finally obstruction in the bile ducts, and that is called as obstructive jaundice. So these are the three things which we have to remember. Now, of course, from there we have moved to much more complex things, and all these several proteins have been described which are responsible for the metabolism of the bilirubin, and each of these can cause a disorder. But remember, these are extremely rare and will be seen in less than 0.01% of the population. So therefore, we should not be focusing on these, but rather the basics of approach to a patient with jaundice. So let us start with the first thing, and that is something called as unconjugated hyperbilirubinemia or increased indirect bilirubin. So when somebody is jaundiced, it could be because of rise in direct bilirubin happen because the bilirubin is being produced extra, for example, in hemolysis, or if there is ineffective erythropoiesis, or patient has developed a hematoma. And then when this hematoma is being reabsorbed, that is the time bilirubin can go up, following blood transfusions and following any hemolysis. The hemolytic anemia causes like G6PD or sickle cell, then you can get increase in the bilirubin. Then you can have bilirubin which is produced normally but does not undergo conjugation, that is, does not undergo metabolism in the liver. And this, the most common is Gilbert syndrome, followed by Crigler-Najjar, which is extremely rare, so you can forget about it. And then you have certain medicines which can cause unconjugated hyperbilirubinemia, and those are the chemotherapeutic drugs like irinotecan, but of course that is again rare. But something which is far more common is rifampicin. So that is something which I would request everybody to remember, and ART drugs like atazanavir and indinavir. Now I'll spend a few seconds on Gilbert syndrome because remember, 7% of the population can have Gilbert syndrome. So if you test everybody in the population, up to 7% of people may have a high unconjugated bilirubin, and therefore they may unnecessarily get investigated for a liver disease. And therefore, we have to be very, very cautious about this. So how do you know when a patient comes with jaundice, whether we are dealing with a pre-hepatic cause or an indirect hyperbilirubinemia or an unconjugated hyperbilirubinemia? The clinical clue is the color of the urine. So a patient who has jaundice, but the color of the urine is normal, is not a hepatocellular jaundice or not an obstructive jaundice. This patient is a indirect hyperbilirubinemia. A very simple investigation to differentiate whether the bilirubin is conjugated or unconjugated is actually a urine test, which is urine bile salt bile pigment. The problem with bilirubin conjugated or unconjugated or direct or indirect is that direct indirect is measured by most of the labs, and direct and indirect is actually a measurement of the solubility of bilirubin, and therefore it can actually be erroneous if there is exposure of the blood sample to sunlight. So exposure to sunlight can make the interpretation of bilirubin unreliable, and therefore whenever in doubt, do a simple test called as urine for bile pigments, and if you find that urine has got bile pigments, then you know that it is conjugated bilirubin which is increased. If the person's serum bilirubin is high, but the bile pigments are absent in the urine, then we are dealing with unconjugated hyperbilirubinemia. Another problem that happens is, an exception is in patients with cirrhosis. When patients with cirrhosis develop hemolysis, then you will not see only unconjugated bilirubin rising. These are the patients where both direct and indirect bilirubin rise. And don't be surprised in patients where bilirubin suddenly has gone to 30, 40, 50, 60. There almost invariably you will find a combination of liver disease and hemolysis. So how do you approach? What history we take? And you remember 8 P's in your history. So any patient with jaundice, 8 P's we have to ask. Which are these 8 P's? First is prodrome. That is, before the onset of jaundice, did the patient get fever, malaise, anorexia, vomiting? If any of this is present, then viral hepatitis becomes much more likely. Second is pruritus, itching. So if the patient has itching, it usually indicates cholestasis. Now, it could be intrahepatic cholestasis or extrahepatic cholestasis, but it indicates that the bile flow is impaired. Either the bile is not being secreted from the hepatocytes into the bile ducts, or there is a blockage in the bile ducts. Third thing you ask for is past history of recurrent jaundice. So if you find that people have recurrent jaundice, then there are very limited differential diagnosis like alcohol, hepatitis B, Wilson's disease, autoimmune hepatitis. So, and then you have congenital disorders like Gilbert Syndrome, Crigler-Najjar, Brake, and PFIC. So, very limited causes of recurrent jaundice are there. Then stones can also cause recurrent jaundice. Then you always ask for history of previous medications. That is the fourth P, including complementary and alternative medicines and any over-the-counter drugs. Very often patients do not count over-the-counter drugs or complementary and alternative medicines as drugs, and therefore you have to specifically ask for them. Then you ask for past history of surgery or interventions done, especially gallbladder surgery, bile duct surgery, liver surgeries, or pancreatic surgeries, because these are, or interventions like doing ERCPs, because these may be associated with strictures. Then prior or current hepatic decompensation. So decompensation is defined by presence of ascites, GI bleed, or encephalopathy. So if the patient has history of prior or current hepatic decompensation, that is history of ascites or encephalopathy or GI bleed, then we know that we are dealing with a parenchymal liver disease and hepatic cirrhosis. Then the important thing is persistent prodromal symptoms is a very important P that you have to ask. In acute viral hepatitis, initially the patient gets prodrome. That is why it is called as pro, because they happen before the onset of jaundice. And once the jaundice starts, within few days, the prodromal symptoms disappear. The jaundice can progress, can keep on increasing over a period of time, but the prodromal symptoms would have disappeared. So if you have persistent prodromal symptoms, that is, patient remains anorexic, still is losing weight, is still vomiting, is still having fever, then you are not dealing with a simple viral hepatitis. Then you have to think of other disorders. It could be a malignancy, it could be infiltrative disorder, or it could be infection which is there in the liver. So a persistent prodromal symptom is a very important history which we need to take. And last but not the least is prolonged alcohol consumption. So there's nothing like a safe limit of alcohol. Any amount of alcohol, you require person to consume at least 30 to 40 grams of alcohol for 5 to 10 years in case of males, and 10 to 20 grams of alcohol for 5 years in case of women for significant liver damage. So if this history is present, then you can safely assume that alcohol could be one of the important contributory causes. Now, in the history, what are the hints that we get? Past episodes of jaundice, we discussed. Alcohol, especially what I have seen is we are somehow reluctant to take this history in case of women. Today, 30% of my patients with alcoholic liver disease are actually women. And somehow there is a social stigma where we are reluctant to take this history from a particular gender, and therefore we tend to miss. So in a young woman or a middle-aged woman, if you find hepatomegaly, elevated GGT, and jaundice, please always ask for history of alcohol, and always ask this when the patient is alone, not in front of the family members. Drugs, we discussed in detail what all has to be taken, including alternative medicine, CAM, and prescription medicines. If in past surgical history of cholecystectomy, old GB surgery, Kasai surgery, hepaticojejunostomy, and history of instrumentation to the biliary system. All these histories have to be taken. Now you come to examination in this patient. What are the clues? Hepatomegaly. Majority of the cases where there is acute viral hepatitis or chronic liver disease or cirrhosis of liver, you will get hepatomegaly. Absence of hepatomegaly in a patient with jaundice usually indicates a end-stage liver disease, and that is not a good sign. A palpable gallbladder in a patient with jaundice by Courvoisier's law would indicate a high chance of malignancy and obstructive jaundice. So it tells palpable gallbladder is usually indicative of a lower cholangiocarcinoma, periampullary cancer, or a pancreatic malignancy. Then you look for signs of hepatocellular failure, which all of you are familiar with, and that is what tells you that this patient is having decompensated cirrhosis. For example, gynecomastia, loss of axillary hairs, loss of secondary sexual characteristics, and hepatic encephalopathy. If you find scratch marks or excoriation, then you know you're dealing with a cholestatic jaundice. And if you find xanthelasmas or xanthomas, that is cholesterol deposits, then you know that you're dealing with a chronic cholestatic disorder. So now we have first identified how to distinguish a pre-hepatic cause or a indirect hyperbilirubinemia. Now the next differentiation comes whether we are dealing with a hepatocellular or a cholestatic, that is obstructive jaundice, and in cholestatic whether it is an intrahepatic or a extrahepatic disease. So let us see what are the causes of hepatocellular jaundice. Common causes: viral hepatitis, but do not forget the occult hepatotropic or non-hepatotropic infections, viruses like EBV, CMV, HSV. They are rare, but they can cause. Similarly, the non-hepatotropic viruses like dengue can also affect the liver. Other opportunistic infections like malaria can also cause jaundice, but of course, you all know better that the presentation is different. Then autoimmune hepatitis, a lot of drugs can cause jaundice. I will name some of the common ones: isoniazid, pyrazinamide, phenytoin, all of you are aware. But the others are the ones which I'm seeing much more frequently these days, which go unidentified. Isotretinoin, very commonly treated, used for acne. Clofazimine, again, very commonly being used. It creates the same clinical picture as autoimmune hepatitis. Fluoroquinolones, especially levofloxacin. We very often put our patients on hepatosafe ATT, and we stop the first line therapy and we put them on levofloxacin, ethambutol, and streptomycin or amikacin. If these patients continue to have a worsening bilirubin, worsening LFT, then you must think whether we are dealing with a fluoroquinolone-induced hepatitis and stop the fluoroquinolone. So this is something again which we tend to forget and we have to remember. And history of complementary and alternative medicine, which can induce secondary autoimmune hepatitis-like picture. Then you can have Budd-Chiari syndrome, Wilson's disease, and pregnancy-related liver disorders. So all these are causes. How do you differentiate whether we are dealing with an intrahepatic cause or an extrahepatic cause of cholestasis? Now, in these patients, if you have itching, it does not help, because itching can be there whether it is intrahepatic cholestasis or extrahepatic cholestasis. Clay-colored stools, will it help? The answer is no. Any severe cholestasis can have clay-colored stools. So clinically, the only way to be sure that we are dealing with an extrahepatic cause, that is obstructive jaundice, is if the person has either biliary colic, that is a classical biliary pain, which is a right upper quadrant pain, which starts around half an hour after the meals, peaks over the next 10 to 15 minutes, stays there at the peak for a few hours, and in 6 to 8 hours subsides completely. So if you get this sort of a pain, then you know for sure that you're dealing with the extrahepatic jaundice and it is a biliary colic. Or if you have features of cholangitis, so sudden high-grade fever with chills and rigors, severe right upper quadrant pain, and either hypotension, altered sensorium in the elderly. So all these are features of cholangitis. So either if you have cholangitis or a biliary colic, then only you can say with confidence that you're dealing with obstructive jaundice. Otherwise, on the basis of clinical history alone, you cannot differentiate whether you're dealing with intrahepatic or extrahepatic. On examination, if you find a palpable gallbladder, then you know for sure that the obstruction is there in the lower bile duct, and there you can differentiate confidently that you're dealing with the extrahepatic obstruction. Now, there are several rare disorders which can cause impaired canalicular excretion or mechanical distortion of small and intrahepatic biliary ductules. Now, all these are causes of intrahepatic cholestasis. So, some of the common ones which you should remember is drugs, alcohol, infiltrative liver disorders like sarcoidosis, TB, fungal infections, malignancies. Paraneoplastic is again something extremely common. So, as a paraneoplastic, so you have a CA pancreas, and patients without any metastasis or obstructive jaundice can develop a high bilirubin, and that is called as the paraneoplastic hepatitis. And the causes of mechanical distortion are extremely rare and out of the purview of common clinical practice. Now, Dubin-Johnson and Reuters are some genetic causes which are more common than what we think, but again, these are benign and usually not affecting much, and therefore we don't bother to spend too much time. Similarly, you have these rare disorders called as familial cholestatic syndromes, and very rare, even a gastroenterologist sees maybe 1 in 2 to 3 years. So don't ever get bogged down by these names and do not pay much attention to them. So we'll have a summary approach as to when you actually see the patient. So last 2 minutes, this is exactly what we have to now focus on. How will you approach a patient? So you take the history as we discussed, remember the 8 Ps. And then you do an LFT. In the LFT, along with that, you can ask for a urine for bile pigments if you are suspecting that this could be a indirect hyperbilirubinemia. So if it is indirect hyperbilirubinemia, then rule out drugs like rifampicin. It could be Gilbert syndrome, or it could be hemolytic disorders or ineffective erythropoiesis. So how will you differentiate between them? A simple test, do a CBC and a peripheral smear. If CBC and peripheral smear are absolutely normal, then it rules out hemolytic disease. Drugs we can take by history. So if you are not finding any other cause, the hemoglobin is more than 13, 14, there is no hemolysis, the drugs are not there, then you can assume that the patient has Gilbert syndrome. So you need not do any specific test or challenge test. Those who are privileged, they can do the UGT1A1 analysis to prove that this is Gilbert syndrome. Then if you look at the LFT and you find only bilirubin to be elevated, rest of the LFT is absolutely normal and there is no other clinical feature, then you can be dealing with the inherited disorder of cholestasis, of direct hyperbilirubinemia like Dubin-Johnson and Reuters. But like I said, this is extremely rare and only for theoretical purposes. On a day-to-day basis, you rarely see this. So do not bother about this. Next, we come to what if you find that the patient doesn't have indirect, but a direct bilirubin which is elevated, and you're suspecting that there could be a hepatic or a post-hepatic cause for the jaundice. Now, you always decide whether you are dealing with a hepatocellular pattern or cholestatic pattern. So if the patient has history, which is classical for prodrome, and then the patient has a hepatocellular pattern like SGOT, SGPT is very, very high, more than 5 times elevated, then you know you're dealing with the acute hepatitis. And there you will ask for viral serology, which is the commonest. In children, hepatitis A, in adults, hepatitis E, and you will also ask for hepatitis B. And in such cases, if you do not find other causes, you will ask for IgM anticore antibody to see if the patient has acute hepatitis B and the patient is in window period. You will also ask for history of toxins like paracetamol or in our cases, Retol. If you still don't find, then you'll ask for rare causes like Wilson's disease and autoimmune hepatitis. If they also come negative, then we'll go for even rarer causes like rare viral infections. And if those are also negative, then we'll do a liver biopsy. In cases where we find that there is cholestasis, that is a gamma GT is elevated, alkaline phosphate is elevated, bilirubin is very high, but SGOT-PT is only mildly elevated, not very high. Then your next step is to do an ultrasound to see if there is a problem in the bile ducts or the problem is within the liver. If you find the dilated bile duct or IHBRD, intrahepatic biliary radical dilatation, then you are dealing with the obstructive jaundice. And if you find this, then you go for a CT scan or an MRCP. If an ultrasound does not show any dilatation of the ducts, then you're dealing with the intrahepatic cholestasis, where again you look for causes of intrahepatic cholestasis like viral hepatitis, alcohol, drugs, and AMA. If you find a cause in this, then fine. If you don't find all these are negative, then you'll do a MRCP. And if that is also not contributory, then you may decide to do a liver biopsy. So this is today how we approach, in summary, patient with jaundice. So I think I finished on time. That was my last slide. Thank you very much. This is our new department, which we have just established in at Sir H.N. Reliance Hospital. And I will now invite Dr. Aditya Kale to discuss and present and discuss the case. And I will request all the panelists to join. I'll request Dr. B.D. Goswami, sir, Dr. Acharya, sir, and Dr. Ashok Chaudhary to join me for the panel discussion. And Dr. Aditya, if you can start discussing the case. So Dr. Aditya Kale, I'll introduce. He is the assistant professor at State GS Medical College and KEM Hospital in Mumbai. And he is one of the rising stars in the city of Mumbai. So over to you, Aditya.
Thank you very much, sir, for a kind introduction. And now we will have an interesting case over here for discussion. So he's a 45-year-old male patient. He presented with jaundice since 1 month, associated with dark colored urine and pruritus. There is no history of ascites, gastrointestinal bleeding, hepatic encephalopathy. He took some alternative medicine after the onset of jaundice, but there was no improvement, so it was discontinued. Since 1 month, he is also having anorexia and weight loss. He occasionally consumes alcohol once or twice a week. There is no significant comorbidities or past medical or surgical history. On clinical examination, he is having 5 centimeter palpable hepatomegaly. Spleen is not palpable. There is no ascites, no encephalopathy. So I will put this question to Dr. S.K. Acharya, sir. Sir, how we will, this is our clinical snippet. So what could be the origin of this, probable site of origin of this jaundice?
I think Dr. B.D. Goswami, sir, can you take this question? You have to unmute yourself.
So it is obvious probably from this the presentation what I have seen here, probably it may be a case of.
Can you go back to the previous slide, Aditya?
You go back to the slide.
Akash, sorry, I was muted. Sorry.
Okay.
Okay, sir. Okay, sir. Yeah. Asaji sir.
Yes.
So this is the case presentation. So what is your...
Yeah, I understand. Can I summarize it?
Yes,
Sir.
Yes, sir.
I think the young man presented a patient of a middle-aged person with a jaundice with itching. Essentially, that was his presentation.
Yes.
I presume the itching was onset of itching was with the jaundice or prior to jaundice or simultaneously with jaundice. I didn't know that. And obviously, there was no fever or pain, but I didn't know about the clay-colored stool, whether he has a clay-colored stool or not. Confirmed further, indeed, it is a cholestatic liver disease, right, without any pain or cholangitis. Second important point in the history he told, he has a large liver, hepatomegaly of 5 centimeters. Now, cholestatic jaundice with a large liver, right? Usually, first thing, the cholestasis starts from the beginning. Second thing, it is not preceded by classical prodrome. Third thing, the liver is 5 centimeters enlarged. And fourth thing, there is features of cholestasis. So obviously, it will indicate a cholestatic syndrome or cholestatic hepatitis. Well, to say that it is intrahepatic or extrahepatic cholestasis, you need further inputs. It can be intrahepatic cholestasis, but as well, it can be extrahepatic cholestasis. It will be under the circumstances difficult to differentiate. I will not be very bold, and I will not ask the physician to extend their imagination further, because the clinical clues are very soft at this point.
Great. So Aditya, can you proceed with the case?
Yes, you should.
So these are the investigations which are available.
No, besides physical finding, I asked you certain probing questions. Did he have pain? Did he have fever? Did he have a clay-colored stool? Did he have
No, sir.
past history of such jaundice? Right?
No, sir. No, sir.
And
No.
any family history of jaundice?
No, sir.
Right.
No family history of jaundice.
So all these informations are probably necessary in the history. Right. For example, a patient can have benign recurrent intrahepatic cholestasis. Right. He may have a large liver if he has a fatty liver disease or something else. The family history is always important. Okay.
Yeah,
So these are the investigations which are available to us. So hemoglobin is 9.5, platelets are 234,000, total leukocyte count is 9,000, bilirubin is 10 total, direct is 7.2. Alkaline phosphatase is, ALT is 140, AST is 120, alkaline phosphatase is 824, normal limit is 140, albumin is 3 gram, gamma glutamyl transpeptidase is 320. So I will, so the next question to Dr. Ashok Chaudhary, sir. Sir, how will you interpret this particular liver function test report?
Ashok,
are you around?
Dr. Ashok sir updated me that he is leaving for some time and then he will rejoin for some family emergency.
Then I'll ask Dr. V.D. Goswami. Can you take the question?
Yeah, so this is the presentation what we have got now. Bilirubin, mostly it is direct bilirubin. Hemoglobin is less, definitely. Albumin is low. Maybe it is related to the alcohol-induced liver disease.
Dr. Goswami, I think it indicates simply cholestatic liver disease. His alkaline phosphatase is raised. His GTTP is raised. It is more than 10 times upper limit of normal. In contrast to AST and ALT, which is less than 5 times to upper limit of normal.
Correct.
So such a pattern goes in favor of a cholestatic liver disease. And here, as Dr. Akash Shukla had pointed out, there are certain differential diagnoses of cholestatic hepatitis, cholestatic liver disease, hepatitis I told. Right. And he has given a list of cause. So friends, the clinical case that presented to you first is the jaundice. That is step 1, as Dr. Shukla described you on practical slides of his first note. And step 2, what is the type of jaundice? Whether it is a hepatocellular, hemolytic jaundice, hepatocellular jaundice, or cholestatic jaundice. This is the step 2 of this individual case, which Dr. Shukla described in his initial introductory lectures. So in the step 2 liver function test reveals cholestasis. That is very important. And as Dr. Shukla had pointed out, cholestasis can be intrahepatic as well as extrahepatic causes. So the next step, obviously, they will try to find out that whether it is an intrahepatic cholestasis or an extrahepatic cholestasis. First thing they will do in such a patient, a simple imaging, which is non-invasive, can be repeated. And that's widely available and less expensive. And that is an ultrasonography. And certain serological marker, right, simultaneously to know whether also intrahepatic causes are responsible. That's what probably the investigation will reveal. That's what you will think. Am I right, Dr. Shukla?
Yes, sir. Completely agree, sir. So in fact, that was the part of the next question, that which of these 4 tests you would do: viral markers, ultrasound, AMA, or liver biopsy. And as you said very appropriately, sir, we would always do an ultrasound because it is a very simple test to differentiate whether there is a intrahepatic cholestasis or a extrahepatic cholestasis. That is, the cause of jaundice is within the liver or it is in the bile ducts. And with this one simple test, you are right more than 98% of the times. So in such cases, I think ultrasound is the first and the very reliable test to differentiate between extrahepatic and intrahepatic causes of jaundice. And here in this patient, an ultrasound is done, which is not showing any extrahepatic obstruction. The bile ducts are normal. So then we know that although the clinical picture is that of cholestasis, this patient does not have an obstruction, and the most probable cause is within the liver.
What will be the next step in this particular patient with cholestatic jaundice and extrahepatic obstruction ruled out?
So I'll take up this question. So now we know that we are dealing with the cholestasis, that is impaired secretion of bile within the liver. So it is a dysfunction of the hepatocytes or bile ducts within the liver. So then here you would want to, 1, rule out common causes like acute viral hepatitis. You would want to rule out other causes of liver diseases like alcohol in this patient. So you would always reconfirm whether the person has been taking alcohol or not. Like Dr. Goswami just mentioned, that alcohol will still be in differential diagnosis, although he claimed that he has alcohol very occasionally, once a month or so. But we have seen this very often, that the patient underreport, and therefore you have to really probe deep into the history. And if you would also do, along with that, if you don't find any other cause, probably MRCP to look at the smaller bile ducts within the liver, and also to be sure that the ultrasound has not missed out on obstructive jaundice. So that would be the sequence in such a case.
Akash, can I comment on this? So sometimes what happens in our practice here in Northeast, we used to see patients, those who used to take some herbal medicines, some herbs. So after that, they used to show this type of picture at the same time. So there may not be any obstruction. Ultrasound is normal, but bilirubin is high. It may be mostly the direct bilirubin, but there is a history of some herbal medication. So probably we have to take that question to the patient also, because initially they used to ignore it, or they used to refuse it to take. But that is, I think, important point for the history. Is it?
Right. I agree completely, sir. I think it's everywhere. We do face patients who have consumed alternative medicines or herbal herbs, and very often on their own without any doctor's prescription, and then they'll end up with jaundice where no other explanation is found. Completely agree. Can we move on?
So viral markers and autoimmune markers are negative. We reconfirm the alcohol intake, and it is very occasional, once a month. And herbal, he has taken a CAM, but that has happened after onset of jaundice. That is for just 2-3 days. Then subsequently it was discontinued. So what is the next step in evaluation of this particular patient?
Another point I want to say, because the history of taking herbal medication, what is in my practice, what my experience, they used to take these herbs for only 1 day or 2 days, even maximum for 3 days. But they have got the picture of the cholestasis for a long, long time, even for months I have seen. But history is only for 1 day or 2 days or maybe 3 days. We cannot say what happens internally, but ultimate picture is for a long time they used to present with the cholestatic picture. So 1 or 2 days history does not mean that it has not got any effect from the herbs. So we should remember it. It is, I am not telling that this patient, they have got the herbal medication, but maybe we should not forget about it.
Hello.
Yes, sir.
The first step, as I told, this is a cholestatic liver disease, and there is some element of hepatitis. I agree. Therefore, it is
medicine is still
very
one
important.
of
Sorry, am I audible?
Yes, sir.
It's
Yes, sir,
very
we can
important to
very clearly.
establish whether it is intrahepatic causes or extrahepatic causes. Then this investigation can be limited for the intrahepatic causes and extrahepatic causes. Therefore, I suggested that the choice of investigation here for the specific diagnosis, there are other investigations which are necessary for monitoring of therapy, right? But for specific diagnosis will be an imaging to see whether biliary ducts are dilated, number one. If they are not dilated and they are normal and bile duct is normal, then it is an intrahepatic cholestasis. If they are dilated, it is a extrahepatic or biliary obstruction, whether intrahepatic or extrahepatic. Then the next question is the level of obstruction. It is the intrahepatic cholestasis. Then the etiology for drugs, the virus, the autoimmune, there are various other conditions for cholestatic jaundice need to be searched and tested. And that's what I suggested. I think that is the right approach, and clinically we follow that.
Right, sir. So, sir, now what would you do?
Now we
biopsy
need an ultrasound imaging finding.
So
The
ultrasound
next step will depend upon that, because you are presented with a liver function test with a cholestatic picture. So next step, obviously, what cholestasis? Intrahepatic, extrahepatic, right? So imaging picture will be necessary. And the simple imaging picture is ultrasound. It will not only give you the cause, possible cause, it will also give you the guide for future investigations.
So, sir, we saw that the ultrasound was normal. It was shown by Aditya that ultrasound is normal.
Oh,
And then ultrasound,
okay, the ultrasound doesn't show surgical jaundice. Okay. So ultrasound show a large liver. I presume that he palpated 5 centimeters, and that there is nothing abnormal to point to the etiology. So I presume it is a intrahepatic cholestasis.
Correct.
Yes,
Where bile ducts as well as liver both are involved. The usual causes you yourself has described. Infections, it can be viral predominantly. Non-infective inflammatory disease like autoimmune disease or small duct PSC, right? Autoimmune disease autoimmune cholangitis, or it can be also primary biliary cholangitis initial onset, which is very rare, or it can be drug, or it may be some other unknown cause for bile duct injuries, right? So you have to think about that, and therefore you will first try to find out the etiology. One of the causes is viral, so you will do a viral viral etiology. If they are all negative, then you are in trouble. So what is it, right? So you have asked what are the 3 out of 4 you will first to do. Usually, as a clinical approach in such a patient, you will not do anything empirical. Sorry, I don't like empirical steroid or empirical ATT based on what? It may cause more harm. And basic principle of service or therapy today will do no harm. The question is, for a diagnosis, you are asking whether MRCP or a liver biopsy. You see, under the circumstances, MRCP will give a limited picture or limited information. You need more information, basically. So it will give you a limited information, specifically on bile duct morphology. It will not tell you in details what is going on inside the liver cells. Whereas a liver biopsy, which is also under the circumstances, can be done depending upon the duration of the jaundice. If it is very prolonged, right? It will provide you idea about the liver cell, the bile duct, the inflammatory cell, the pattern of the inflammatory cell, the pattern of liver cell damage, the pattern of their organism, and which is characteristic for certain diseases, but not diagnostic. It will also provide you tissue for doing various immunostaining, right, for a possible diagnosis. So the information from liver biopsy will be more, which will be helpful to achieve a differential diagnosis. That is the way I will analyze it, and I will choose the investigation.
Thank you, sir. Aditya, can we just go back to the previous slide? So once we diagnose that we are dealing with a intrahepatic cause by confirming an ultrasound, there is no obstruction. We looked at all the viral markers, hepatitis A, E, B. We looked at autoimmune hepatitis markers, ANA, ASMA. We looked at PBC, which is extremely rare, but again possible, AMA. So once we have ruled the common disorders, what we are left with in the differential diagnosis is one, like Dr. Acharya said, we could be dealing with a small duct PSC, or it could still be alcoholic liver disease where the patient has still not revealed to us, or like Dr. Goswami said, it could still be a complementary and alternative medicine associated liver injury and cholestasis, and that is again being missed. Now, which of these three, or we still have possibility of infiltrative liver disorders like Dr. Pati has mentioned in the chat box. So all these diseases are possible, and therefore, like Dr. Acharya said, can we go to the next slide? The next step would be to do a liver biopsy. And before we do a liver biopsy, it is always prudent to do an MRCP, which is less invasive, because if the ultrasound report has been wrong or it has been done by somebody who is not so experienced, then there can be an error. And therefore, an MRCP is done, which is normal, and a biopsy is performed. So in such cases, a biopsy would be done to identify which of these is the causes. So can we have the details?
So this is a microscopic photograph of liver biopsy, and it shows that liver cell, the liver is infiltrated with abnormal looking lymphocytes, and it appears, and you can see these diffuse infiltration of hepatic parenchyma by these abnormal looking lymphocytes. And hence in this patient, the diagnosis is hepatic lymphoma. So it was a case of jaundice, cholestatic jaundice with hepatic infiltration by lymphoma.
Thank you, Aditya, for the lovely case. To tell you, in this patient, from the presentation till the final diagnosis took us less than 72 hours. And therefore, this was only because of the clinical approach, which is possible. So once we have a clinical approach, even a difficult diagnosis, a primary hepatic lymphoma is a difficult and a very rare diagnosis, can be reached very quickly. And we have not done any fancy investigation to reach this diagnosis. So that is something we have to remember. We have to keep our basics very clear. And with that, we will be able to diagnose most of the patients with jaundice correctly. Now, there are a few questions in the chat box, and I will take some of these questions. How to identify drug-induced hyperbilirubinemia? This is asked by Dr. Chaitanya Bokil. So I think it is a very important question. There is no single test or biopsy to confirm that this is a drug-induced hyperbilirubinemia. The clues you can get maybe on liver biopsy, and where you can get eosinophilia along with cholestasis, and the other hint you may is basically on the clinical picture, where the temporal relationship of the drug intake with jaundice is there, and the drug is known to cause jaundice. So I think that is where we will be able to make a rough clinical judgment of probable drug-induced hyperbilirubinemia. The next question is, can we get a clue from the peripheral lymphocyte count for this disease? This is asked by Dr. Girish. So the answer is again, this patient's peripheral smear and the CBC was absolutely normal. There was nothing involved in it. And this can happen in primary hepatic as well as primary splenic lymphomas, where the peripheral smear can remain normal for a long period of time. Even the bone marrow can be normal in quite a few cases. Okay, another question which I can see is what about the consumption of alcohol in this patient, whether it is for 5-6 years, or it is what was the significance of the last time the person has drank alcohol. So I think this question will become important when we are suspecting that this could be alcohol-related liver disease. So if we are suspecting alcohol-related liver disease, then the quantity of alcohol consumption, the duration of alcohol consumption, when the last alcohol has been consumed, all become very relevant. For example, if you are suspecting alcoholic hepatitis, then the person should have had alcohol consumption in the last 4 to 6 weeks. Otherwise, it's extremely rare that the patient will develop alcoholic hepatitis 4 to 6 weeks after the person has stopped alcohol. Similarly, for alcoholic cirrhosis, usually if the patient is presented with jaundice, then in the last 6 months, patient would have been drinking for sure. So there are multiple such parameters which you look at. The quantity of alcohol is important to be sure that the liver disease that the person has is probably because of the alcohol consumption. So like I've spoken in my talk, around 30 to 40 grams of alcohol per day for 5 to 10 years in men, and 10 to 20 grams of alcohol minimum for 5 years in women is associated with a significant risk. Now, another question I think has come from Dr. Umesh, which is, can granulomatous hepatitis be a differential diagnosis in this case before biopsy? The answer is absolutely yes. So when we say infiltrative liver disorders, we will think of tuberculosis and sarcoidosis in such cases. So we don't know which infiltrative disorder, but all granulomatous disorders of the liver can present in this way, and they will be part of the differential diagnosis. So I think that's all the questions that we have here. So I would like Dr. Acharya sir to say the final few words before we wind up the session and hand over to the regional coordinators. And I would express sincere thanks to each one of you for logging in. And I would like to thank SINSAN for arranging the GLAD program, and my co-panelists and patron Dr. Acharya sir for having the foresight to develop such a wonderful platform. Thank you very much.
Thank you, Akash. You did a marvelous job. So friends, you learned about approach to actually jaundice. First step, a cholestatic jaundice. And as Dr. Sukla very brilliantly has given you the types of jaundice, and based on the types of jaundice, the differential diagnosis. And in this particular patient, a cholestatic jaundice, which causes are intrahepatic as well as extrahepatic. He has given you approach, the clinical clue, as well as investigative approach to establish the diagnosis. And in such a patient where he did imaging and ruled out obstructive jaundice and thought it is a cause of intrahepatic cholestasis, a liver biopsy gave him the diagnosis of a lymphoma, right, which is a rare cause of cholestasis jaundice, It can cause infiltrative jaundice. It can cause varicose bile duct syndrome. It can cause also idiopathic cholestasis. So various presentation of lymphoma, and he also has given little discussion about the primary lymphoma. These were the learning points of today by a brilliant organization of a lecture, and then the case-based points, which Dr. Shukla and his team has wonderfully done. Thank you, Dr. Shukla, and glad conveys his deep appreciation. Thank you, ladies and gentlemen. Good night.
Sir, can I add one comment, sir, in the field?
Yeah.
Yeah. Good evening, sir, and good evening. So, very good talk by Dr. Akash, sir. And sir, in our clinical practice, we have seen patients with indirect hyperbilirubinemia having NASH also. So, can NASH be one of the DD in indirect hyperbilirubinemia cases like bilirubin of 0.7 or 0.9? They usually have NASH also diagnosis.
Unlikely, but if you see with indirect hyperbilirubinemia, first thing you should think and rule out is a Wilson's disease. Because Wilson's disease is a disease where there can be hemolysis as well as fatty liver. So if you see clinically, if you see NASH with indirect hyperbilirubinemia, and if you establish the cause of hyperbilirubinemia as hemolysis, then obviously that is a clinical pointer for diagnosis and hunting for Wilson's disease. Otherwise, these are associated Gilberts, as Dr. Shukla has pointed out. Or he has taken certain drugs which has caused indirect increase in indirect bilirubin. Right. All other causes of hyperbilirubinemia and indirect hyperbilirubinemia, Dr. Akash Shukla in his lecture pointed out, which you have to rule out by history. So essentially, this should be the approach. You should see why the indirect hyperbilirubinemia is there.
So there is one very good question asked. This question has come from Dr. Biswaranjan Patra. He is a brilliant gastroenterologist in my department, very young, enthusiastic boy. He has asked a question: R ratio is to be used only to determine pattern of liver injury in drug-induced liver injury, or it can be applied for other etiology to determine pattern and further investigations directed accordingly. So, Dr. Acharya sir, can you take this question up?
What is the question? I didn't understand at all.
So he's saying that the R ratio that we use for DILI, whether to understand the pattern of...
Tell me what is R ratio? I don't remember that.
Sir, alkaline phosphatase and SGOTPT, bilirubin. So whether that ratio is applicable only for DILI or it can be applied to all other disorders.
I'm sorry, despite all your guideline, all your ratio between SGOT, SGPT, alkaline phosphatase enzymes, I'm a very skeptical on any of these ratios. I personally don't believe in all this R ratio. I don't personally take them as any clinical or biochemical clue. The other biochemical clues are much robust, right? And gives you a diagnosis in 99.99% of patients. So that's my personal opinion, but you can quote multiple studies on various ratios that I know Akash very well, with their specificity and sensitivity based on a fixed number of patients and negative control. So that will be my personal points. You can correct it.
So for the audience, R ratio is basically ALT divided by alkaline phosphatase. And if this ratio is whether less than 2 to 5 or more than 5. So if it is more than 5, it is hepatocellular jaundice. If it is less than 2, it is cholestatic jaundice. And between 2 to 5, it is considered as a mixed pattern of enzymes. So this is by and large was defined for drug-induced liver injury for clinical trials. And but I think in general, this is basically whether the SGOTPT is more elevated or the alkaline phosphatase GGT is more elevated. If you find that alkaline phosphatase GGT is much more elevated, SGOT-SGPT is less elevated, you know you're dealing with the cholestatic jaundice. This is what Dr. Acharya is trying to say. Yeah. So while it is good for clinical trials, in clinical practice, I think we cannot just go by that 1.9 will be hepatocellular and 2.1 will be a mixed. I think
Look-
here we use our clinical
Look,
judgment and do not get
ALT
guided by
ratio, ALT usually ALT LP, that is the disproportionate rise of alkaline phosphatase, right, in cholestatic jaundice. That is the ALT LP ratio. But ALT LP ratio is not sacrosanct, right? You will be surprised 15% of the cholestatic jaundice will not have raised in alkaline phosphatase. There are many causes of non-rise of alkaline phosphatase in offspring, and there is a large size of number. So based on the rise the ratios, that's not my point. I wanted to make that. Right. That's not the point.
Absolutely, sir. Completely agree.
That's the very careful clinical
Right.
approach, because just simple following blindly guideline will miss you.
So I think I will get too technical, which is not the idea of
Yeah.
today's talk or for guide meetings. We should try to make it as simple as possible, and that was the whole idea behind this whole endeavor. And I think we are already overshot the time, so I'll wind up this session with sir's permission, and would like to thank each one of you for being here, and over to all the regional coordinators, all the eminent gastroenterologists in their cities for taking up further discussion and question answer from the audience. Thank you very much, and see you again next month on the third Friday of the month. Thank you.
Yes, sir.
Bye.
Thank you, sir.
Namaskar, sir.
Bye.